Welcome back to the deep dive. Today we are tackling something pretty intense, a really serious scenario in surgery called burst abdomen.
And it sounds exactly as bad as it is. It's a catastrophic failure of a surgical wound.
Right, the whole thing just comes apart. It takes a patient who should be recovering and plunges them right back into a life-threatening crisis. We're talking massive infection, instability, the works.
It's a complete reset of their recovery.
Yeah.
The abdominal wall, which is, this critical barrier, has failed. And that immediately creates these huge high-stakes problems with contamination and sepsis.
And we've actually been given a protocol for this, a very detailed clinical flowchart that maps out step by step how a surgical team manages one of these cases, from the very first sign of trouble all the way to discharge.
It's a fantastic source, a real masterclass in how you manage a crisis in a controlled way.
So our mission today is to unpack that document for you. Think of it as a shortcut to understanding this incredibly intensive, multifaceted approach.
It shows how a team has to pivot instantly from routine care to this aggressive, specialized intervention.
Okay, let's unpack this, and I think we have to start with the setup. I mean, how does a patient even get to this point?
Well, a burst abdomen is always a consequence of something else. It doesn't happen in a vacuum.
So what's the starting point? What does that initial admission look like?
The journey almost always begins with a severe, acute abdominal emergency. The source material is clear on this. Patients come in with things that scream catastrophe.
Like what specifically?
Agonizing abdominal pain, major distension where their belly is swollen and tight, constant vomiting, maybe a complete bowel obstruction or even full-blown peritonitis.
A massive infection inside the abdomen.
Exactly. The kind of thing that requires immediate, and I mean immediate, surgical intervention.
And that leads straight to the first procedure mentioned in the flowchart.
It does. The most common precursor is an emergency exploratory laparotomy.
So just opening the abdomen up to figure out what's gone so wrong?
Precisely. The surgeon has to go in, find the source, a burst organ, a blockage, whatever it is, and try to fix it right then and there, often under incredible pressure.
And why is that specific situation, an emergency surgery, such a high-risk environment for the wound to fail later on?
Well, the sources point to a few key conditions. Things like perforation peritonitis, where the whole abdomen is just flooded with bacteria.
So it's already a contaminated field.
Totally contaminated.
Sure.
Or severe intestinal obstruction, or sometimes really big cancer surgeries. The key is that these operations are done in a hurry on a patient who might already be septic, dehydrated, and critically malnourished before that first cut is even made.
So their body is already running on empty.
Absolutely. And that's the real insight here. A burst abdomen is often at its core a failure of healing. It's rooted in a severe metabolic problem, specifically a lack of protein. The body just doesn't have the building blocks, the protein, the energy, to make collagen and build strong new tissue to hold that wound together.
That makes so much sense. So the surgeon is closing tissue that's already stressed, maybe swollen, and basically starved of nutrients.
And that's what kicks off the risk phase.
Yeah.
This is why vigilance is so important right after the surgery, even if the wound looks totally fine on the surface. We're talking about post-op day 1 through 7, sometimes even later.
So when we talk about the wound failing, what's actually failing? Is it the skin stitches?
That's a great question. It's not the skin. The skin is just a cover. The catastrophic event is the failure of the fascia.
The fascia? Okay, what is that exactly?
Think of it as a tough, strong, fibrous sheath. It's under the skin and the fat, and it's the layer that actually holds the abdominal wall together. It's the load-bearing layer.
I see. So the surgeon's main goal is to sew that layer together securely.
That is priority number 1. When the fascia gives way, the whole structural integrity is gone, and the abdominal organs, the bowels, are suddenly at risk of literally falling out. That's called evisceration.
And I imagine things like coughing or vomiting, any kind of strain would put a huge amount of pressure on that weakened fascial layer.
A tremendous amount of pressure.
Mm.
And when those sutures tear through that starved, weakened fascia, that's the moment the patient is truly in the high-risk window for a burst abdomen. It's a profound mechanical failure.
Okay, so once we're in that high-risk period, what are the first signs? What are the earliest red flags the team is looking for?
The first and most common sign that something is going wrong deep down is the fluid that starts leaking from the incision line. The team is watching for what we call seropurulent, or even just purulent discharge.
Can you break that down? What's the difference, and why is that so telling?
Sure. So seropurulent is a thin, cloudy, kind of yellowish fluid. It's blood serum mixed with inflammatory cells and, bacteria. Purulent discharge is just thick, opaque pus. Seeing either of those tells you there's an active infection brewing in the layers beneath the skin. It's creating this environment that's basically dissolving the sutures and attacking that weak fascia. Any unexpected fluid is a huge red flag.
And after the fluid, I assume you start to see the physical separation. The sources mention visible wound gapping.
Yes, the patient or a nurse might notice the edges are starting to pull apart, and with that, you often see something called SLA.
Slough, what's that?
SLA is a critical sign. It's dead tissue. It looks kind of yellowish gray, and it's slimy. And it's a major problem because, well, dead tissue can't heal. It just sits there, acting as a barrier and a breeding ground for bacteria.
So you can't heal until you get rid of it.
Exactly. You have to remove it. It prevents oxygen and blood from getting to the healthy tissue.
So you've got this discharge, the wound is gapping, there's dead tissue. And this is often happening alongside internal problems, right? What symptoms is the patient feeling?
Often, they'll have persistent abdominal distension. Their belly feels bloated and tight. And as we said, that's both a symptom of something wrong inside, like the gut has stopped working, and it's the very thing that's creating the physical pressure forcing the wound apart.
So all of this leads to the definitive diagnosis. What's the one thing that makes a doctor say, okay, this is officially a burst abdomen?
It's a diagnosis made by just looking. It doesn't need a special test. The defining moment is when you see the wound edges have separated so much that you can see the bowel loops underneath.
Wow.
Or even worse, the bowels is actually protruding out of the wound. That's the evisceration we talked about. The moment you see the intestines, you know that every single layer of the abdominal wall has failed.
And that sight must just change everything. You go from managing a tricky wound to full-blown surgical emergency.
Instantly. The second you have that visual confirmation, you have to move into a full investigation to understand just how bad the contamination is.
Right. Because the infection is everything here. The flowchart says they do a wound swab for culture and sensitivity right away. Now, they're going to start antibiotics immediately, so why is that test so important?
Because a good antibiotic plan has two phases. First, you start broad-spectrum antibiotics, which is basically your best guess to cover the most likely bugs.
The shotgun approach?
The shotgun approach, exactly.
Yeah.
But the culture and sensitivity, the CNS, that's the sniper rifle. It tells you exactly what bacteria you're fighting and, more importantly, which specific drugs will actually kill them. Without that, you're just guessing.
And the list of organisms in the sources is pretty telling. We've got Klebsiella, E. coli, Enterococcus, Acinetobacter, and diphtheroids. That's a lot.
That list tells a story. E. coli and Enterococcus, those are standard gut bacteria. You'd expect to see them. But seeing things like Klebsiella and especially Acinetobacter baumannii, that really raises the stakes.
Why Acinetobacter? What makes that one so bad?
The Acinetobacter is, it's a notorious hospital-acquired bug. It's an opportunist, and it's frequently resistant to multiple drugs.
Superbug. A superbug, exactly. Finding that in the wound means you're not just fighting the patient's own gut flora. You're fighting a tough hospital-bred infection that could be incredibly hard to treat. This is why that culture isn't just a nice-to-have. It is literally life-or-death information.
And while that's happening, what are routine blood tests showing?
The complete blood count, the CBC, is key. You'll almost always see leukocytosis, a really high white blood cell count. It's the body's alarm bell, confirming that there's a massive systemic inflammatory response happening. The wound is the source, but the high white count tells you the whole body is under attack.
Here's where it gets really interesting for me. The diagnosis is already made visually. You can see the burst abdomen. But then they order advanced imaging, like a CECT scan of the abdomen and pelvis.
Yeah.
What are they hunting for inside?
They're hunting for the hidden source of the problem. You have to know if this failure has created new disasters inside the abdomen that you can't see.
What kind of disaster? Three main things. First, they're looking for collections, pockets of pus, or abscesses that are walled off and need to be drained surgically.
Okay.
Second, and this is critical, they look for extravasation of contrast.
Okay.
For the scan, the patient gets an IV or oral contrast dye. If they see that dye leaking out of the bowel.
That means there's a hole. The original surgical repair inside has also failed.
Exactly. It's a persistent internal leak. It means the patient is still being contaminated from the inside, which is a surgical time bomb. You have to go back in and fix that.
Wow. And the third thing.
Dilated bowel loops. If the intestines are really swollen and blown up, it suggests there's still a blockage or that the gut is completely paralyzed. And those findings are what determine the next step. You can't just close the skin if there's an undrained abscess or a massive leak inside. The imaging tells you if you need to go back to the operating room and what you need to do when you get there.
So with that investigation running, the immediate life-saving actions are all about stabilization. You've got an open wound, exposed organs. What is priority number one for the wound itself?
Protection and decontamination. Aggressive, daily, meticulous cleaning and dressing. You have to protect those exposed organs from drying out and from getting further contaminated.
The sources list a specific mix of solutions: betadine, hydrogen peroxide, and saline. Why that combination? I'm particularly curious about the hydrogen peroxide.
Each one has a job. Saline is for gentle irrigation. Betadine is a powerful, broad-spectrum antiseptic, and hydrogen peroxide, the H2O2, is useful here for a couple of reasons.
Okay.
First, that bubbling action, the effervescence, it physically helps lift debris and slaw out of the wound bed. It's a mechanical cleaning agent. And second, it releases oxygen, which helps kill anaerobic bacteria, the kind that hate oxygen and thrive deep in contaminated wounds.
And what about the dressings? They mentioned paraffin gauze.
Right, use something non-adherent like paraffin gauze because the surface of the bowel is incredibly delicate. You don't want the dressing to stick to it and cause damage when you change it.
The flowchart also mentions a mechanical technique called cross-strapping dressing. What's that for?
Cross-strapping is a temporary measure to try and bring the wound edges a little bit closer together. You use adhesive strips, kind of like butterfly bandages, but on a much larger scale, to apply gentle, continuous tension.
And what does that do?
It reduces the size of the open area, which lessens contamination risk, but it also just helps contain everything and provide some comfort and support for the patient. It makes a very unmanageable situation a little more manageable before the definitive surgery.
So that's the local wound. At the same time, you're managing the whole patient systemically. What's the foundation of that support?
5 fluids and pain relief. Without a doubt, these patients are losing huge amounts of fluid from the open wound. You have to pour fluids in to keep their blood pressure up and protect their kidneys. And powerful analgesia, pain relief is absolutely essential.
And of course, the antibiotics, we touched on this, but the initial drugs are things like ceftriaxone, metronidazole, piperacillin, tazobactam.
Very powerful, broad-spectrum drugs. The goal is to hit the infection hard and fast with something that will cover all the likely suspects. Metronidazole is great for anaerobes from the gut, and the others cover a huge range of other bacteria.
But the flowchart stresses that you have to adjust these later based on the culture results.
Yes, and this is so important in modern medicine. You de-escalate. Once you know exactly what the bug is and what it's sensitive to, you switch to the narrowest spectrum, most targeted drug possible. It's better for the patient, and it helps prevent antibiotic resistance.
And finally, nutrition. If the whole problem started because the patient was malnourished, then feeding them isn't just a comfort measure, it's therapy.
It's the engine of healing. Their metabolic demands are sky high. They're burning through calories and protein trying to fight infection and heal this massive defect. So the priority is always an oral diet if they can tolerate it, with a huge emphasis on high protein.
But what if they can't eat, if their gut isn't working?
Then you go to total parenteral nutrition, or TPN. That's when we give all the nutrients, protein, sugar, fats, vitamins, directly into the bloodstream through a big IV line. It completely bypasses the gut. For a patient who is breaking down their own muscle for fuel, TPN is a lifeline. It provides the building blocks they desperately need to start healing.
And the last stabilization piece is the abdominal binder.
Right. It's just a large elastic support that wraps around the abdomen. It provides external compression, which reduces tension on the wound, helps with pain, and makes it easier for the patient to move around.
So now the patient is stabilized, the infection is being treated, they're getting nutrition, we're moving into the definitive surgical fix.
Exactly. And the choice of what to do next is very tailored. It depends entirely on how big the fascial defect is and if there's still any complications going on inside.
And the main goal, I'm guessing, is to close it without tension.
That's the golden rule of surgery. Tension on a suture line cuts off blood flow. No blood flow, the tissue dies and the repair fails. You have to avoid tension at all costs.
Okay, so let's look at the options. Option A is secondary suturing. When is that used?
That's for smaller defects, where the gap isn't too wild. After the wound is cleaned up and healthy, the surgeon can go back and directly suture the fascial edges together again. Secondary just means it's the second attempt at closure.
But if the defect is too big for that, they use option B, tension band suturing. How on earth does that work?
It's a really clever technique.
Yeah.
Instead of trying to pull the wound edges directly together, which would just tear the tissue, the surgeon places really big, strong sutures far out to the sides of the wound.
Okay.
And they tie these sutures over little bridges on the skin, like rubber tubing. This distributes all that pulling force over a wide area of strong, healthy tissue instead of right on the delicate wound edge.
I see. So it pulls from the sides, not from the middle.
Exactly. It gently encourages the wound edges to move closer together over time, reducing the gap without strangling the tissue. It's a dynamic, tension-reducing solution.
But before they do any of that, the flowchart says debridement is essential. That's cleaning out the dead tissue, right?
It is non-negotiable. You cannot sew healthy tissue to dead tissue and expect it to heal.
Yeah.
It will always fail. The surgeon has to go in and surgically remove all the slough, all the necrotic fat, until they get down to healthy, pink, bleeding tissue. That's the only way you know you're working with viable tissue that can actually heal.
And then we have the most complex scenario. What if the imaging showed a persistent problem inside? A leak, an abscess?
That's when the team has to make the tough call to go back in for a full re-exploration or revision surgery. If there is an uncontrolled source of infection inside the abdomen, you have to deal with that first. You can't fix the wall if the house is on fire.
So what kind of internal failures would require another massive operation?
The big ones are a persistent leak from an anastomosis, where two bits of bowel were joined together. That is now broken down. That means intestinal contents are still pouring into the abdomen.
Just constantly reinfecting everything.
Constantly. Or a big undrained abscess, or an ongoing bowel obstruction. These are things that have to be fixed surgically.
The sources mention a revision colostomy. Can you explain why that would be necessary?
Okay, so imagine you have that leaking anastomosis. The tissue is inflamed and infected, and you can't just re-sew it. So to give it a chance to heal, you have to divert the fecal stream away from it.
You create a detour.
Exactly. You bring a healthy piece of colon up to the skin surface to create a temporary stoma, a colostomy bag. All the stool comes out into the bag, completely bypassing the damaged area downstream. This gives the internal leak a clean, quiet environment to heal. It's a life-saving maneuver.
So once that definitive surgery is done, the patient enters the long road to recovery, which involves a ton of monitoring.
Constant, watchful waiting. They're checking vital signs for any hint of returning sepsis, of course.
Okay.
But the real focus shifts to the wound itself.
And what are the signs that the wound is finally actually healing?
You want to see the discharge decrease and the slough disappear. But the gold standard, the sign that makes every surgeon breathe a sigh of relief, is the appearance of granulation tissue.
I've heard of that. It's that pink, kind of bumpy-looking tissue that fills in a wound, right? What is it?
Physiologically, it's a sign of victory. It means the body has beaten back the infection and has enough resources to start rebuilding. It's brand new connective tissue and tiny new blood vessels. It's the foundation upon which new skin will eventually grow. It means the wound is healing from the bottom up.
And at the same time, they're watching for the gut to wake up.
Absolutely. Are they passing gas? Are they having bowel movements? You need the GI tract to be working again so they can start eating properly and getting that high-protein diet they need to fuel all this new tissue growth.
All of which leads to the discharge criteria. What does a patient have to achieve to finally go home?
It's all about stability. They have to be vitally stable, no fever, normal heart rate, and they have to be tolerating food by mouth.
Now, this part from the sources really surprised me. It says they can be discharged even if there's still a gap in the wound.
Yes. This is the concept of healing by secondary intention.
Wait, so they send them home like that, with an open wound?
They do if the situation is right. If the patient is stable, eating well, and the wound bed is clean and full of that healthy granulation tissue, the acute crisis is over. The slow, gradual process of the wound filling in can safely continue at home.
Wow, that must make for some pretty intense home care.
It's incredibly demanding. They go home with a detailed plan. They're usually on oral antibiotics for a while longer. They have to continue the daily cleaning and dressing routine. The abdominal binder is still mandatory for support.
And the diet, I assume.
The high-protein diet is non-negotiable. Healing by secondary intention is a massive metabolic project. It takes months and a huge amount of protein to rebuild all that tissue. And, of course, they have regular follow-up appointments to make sure everything is continuing to heal as it should.
So what does this all mean? When you look at this flowchart, it's not just a checklist. It's a strategy.
It's a highly rigorous phased strategy. It shows that every single step, from identifying the right bacteria to making sure they get enough protein shakes, is all calibrated to support the body's own slow, diligent healing process and pull the patient through an incredibly vulnerable time.
This has been a really fascinating deep dive. We've tracked this whole journey from that initial crisis of the fascia failing under stress through all the tailored surgical solutions and the incredible supportive care needed to get them through it.
What really stands out to me is the diligence, the systematic approach to finding and controlling the source of the infection, both inside and out, and then just relentlessly supporting the patient's nutrition to give them the fuel to heal. That's what makes the difference.
And we ended on that surprising note that patients are often sent home with the wound still open, healing by what you called secondary intention. The big battle is won in the hospital, but the long war is really fought at home.
That's a very good way to put it.
So, after all of that intensive medical care, the emergency surgeries, the IVs, the powerful drugs, the patient is brought back from the muck. But their recovery is far from over. So here's a provocative thought for you to consider. Given the visibility and the sheer vulnerability of managing a large open abdominal wound at home for weeks or even months, what are the overlooked psychological and emotional challenges? The fear, the isolation, the constant burden of care when your healing has to happen quite literally from the inside out.
It's a profound shift. The responsibility for what is still very complex medical care moves directly into the patient's private life long after the acute phase is over.
Thank you so much for breaking down this incredibly detailed flowchart with us. It gives you a real appreciation for the dedication this kind of care takes.
It was a pleasure. It's always great to unpack these complex protocols.
We'll catch you next time for the deep dive.